Thank you very much, and thank you to my friend Dr. Hyap for inviting me. Um I'm going to quickly move through some of these slides because there's a little bit to cover. I think there's no better place to see the conglomeration of imaging than the ICROP 2021, where you see that how angiography shows us capillary non-perfusion in the periphery when aggressive posterior ROP is now dropped, and we just call it aggressive ROP, and different subtypes of aggressive ROP. In the classification itself, we are now looking at digital extraction of these vessels and trying to make a p-score out of it to see how severe this is. So that's on one end where it's coming to the classification. You're perhaps familiar with the Indian camera that's been now around for 8 years, has an FDA approval. It was in this paper we compared the two devices, the RedCam and the Neo, but now it also has the angiography module. And this is a clinical study we just completed in the NICU at the bedside doing angiography, and you know how useful that is, especially in the era of anti-VEGF. There are other lens holders which use iPhones and other cameras. These are good for posterior pole, but not really for wide field imaging. Now, I'm just going to dwell a little bit on angiography. So this was a case lasered and injected elsewhere, came to us at 1.5 years of age. And the picture looks very innocuous, but look at the angiogram. It shows you what an active disease there is. It's still neovascularization, so much of avascularity, and the laser marks are so far away. And that's what you can detect and treat well with angiography. This is really the standard procedure, and my friend Vici will cover it, so I'm going to cross over. But angiography, especially in the post-anti-VEGF era, has helped us look at how the peripheral avascular retina and neovascularization has to be treated. And unfortunately, recurrences happen 3, 4, and 5 years after injection if you've not detected it. So I'm just presenting some of our cases. So this is the occlusive type of aggressive ROP, which we unfortunately see very commonly in India. And this is 10 weeks later. It looks good, plus is gone, vessels are growing forward. And another 4 weeks later, almost 14 weeks after that injection, look at the amount of avascular retina. This is now classified as persistent peripheral avascular retina, can be dealt very well with laser. And we do all the lasers in India under topical anesthesia. So if a baby is going to become 6 and 7 kgs, that's going to be hard. So we have certain protocols, and I'll present that in another talk. Now, this is just to show you that sometimes the recurrences happen and they're not often detected clinically. These babies are difficult to examine as well, but so much easily picked up on angiography. My idea of showing you the next case asymmetrical is that not all the recurrences happen symmetrically in both eyes. Whereas in one eye, you will see it going towards the aura and you just see persistent avascular retina. In the left eye on your right, that is, you see a very classical recurrence with stage 3. So here you have to manage them differently. The left eye is going to be treated right now with laser. The right eye can be followed up and using the protocol, perhaps treated with laser many weeks or even months later for the small amount of persistent avascular retina. The good part is when you follow them up, if you've treated them well, their vision and their refractive error is comparable. You might want to think that after anti-VEGF, you'll see less myopia, not really true. Now I'm going to deal a little bit with OCT. We've had some work in this area. So this is a very standard infant OCT where you see that the inner retinal layers don't fuse. And let me now show you, and this is correlated very well with pathology. This is some of our babies that we've been following up serially. So that's 38 weeks. And look at how the ellipsoid zone is far away. So it's just one layer at the foveal zone. And as the weeks grow, as this baby grows older from 46, 47, and 48, voila, you have 2 layers, which basically means that a preterm baby may not be born with the photoreceptor layer at all, the ellipsoid zone, and it's going to start happening. Also, along with that thing, you saw that the inner retinal layer started to fuse, and you have that IRL fusion at that age. And what we went on to do is correlate these layers with and without vision and with and without ROP. So if any of these layers took longer to come or didn't come at all, did it code for poorer vision, and in which subgroup we saw it in. And what we found is, while we were looking at the periphery, we found 2 patterns of macular edema of prematurity. This was published some time back in IOVS, where we found that the pattern B now is a great marker for cortical vision impairment, which is again very common in preterm babies. looking at, so this was the paper where we looked at all those different layers. If they come late, how they would code for poor vision at 3 months, 6 months, and then they recovered with vision rehabilitation. And sometimes your pediatric ophthalmology colleague will send you these cases where they've tried everything possible with amblyopia therapy and the vision is still not improving. And OCT can sometimes give you the answer. Look at that. This is otherwise no anisometropia, 6.6 in one eye and 6.18. When you look at the ellipsoid zone, you can see it's bifid, it's broken. For whatever reason, there is a loss. And this is some of our work in rubella retinopathy, where you see a very jagged tooth-like appearance of the outer plexiform layer. Just now, Madam referred to Down syndrome. We've published some work on Down syndrome in OCT. And what's interesting here is up till the age of 2, their OCTs resemble that of a normal child. And after 2, when they start having intellectual disability, their layers and their OCT findings also lag behind. And that's when it starts looking very different. This is our pattern B, and it was further validated by the Duke group, which showed that this is different from the edema that you see in preterm, but this is more seen in hypoxic ischemic encephalopathy, and that's how you differentiate it. This is some work we've done in OCT angiography. This was probably the youngest baby ever to be imaged on OCTA, and we looked at then the older cohort between age 5 and age 10, and we found that even if they did not have treatment requiring ROP, just the fact that they were born preterm had abnormalities in the superficial plexus, but some of that deep plexus seemed to be preserved. Contrast, we are now able to measure contrast in these babies right at their first and second screening. And the best part is we are able to correlate this contrast with the vision that they will develop 3, 6, 9 months later. Universal screening has caught on in India. That's government sponsored right now, but it's still in execution. We are lacking behind. And this is some of the initial work we found. What else, like Dr. Zainab presented, the other conditions that we would find while screening for ROP. And then this paper went on to look at what we would see in babies. So we've now cut short our training for ROP programs across the country. They spend a few days with us and the rest of it training happens on site. Unfortunately, these processes were in place before the COVID pandemic. I'm just going to end with some very exciting AI ML, and I know that's one of the themes of this conference. We've been working on this for about 10 years now, where we look at bad quality images that come out of any camera and see how you can enhance the features. This is some of our publications that look at the vascular enhancement, both digitally and optically. And we've come to a point of time, and this most recent paper shows us about a 90% accuracy of detecting stage 2 and stage 3. So that's the IR image that has been detected by the algorithm, and that's the lower images, the AI platform, which is telling you the one on the left is stage 2 and the other one is stage 3. So this is good, but not awesome. What we are trying to do now is integrate it with our training mechanism. So as a technician is going to be trained to take images, the AI model will be put into the camera, and instantly there will be a score telling the technician that, this is possibly the diagnosis. So you can, of course, this remains to be validated, but this is a clinical study we are doing with the support of the Indian government. And this is our most recent publication where we are validating this as a tool where we are integrating it into the camera. This is a review paper that was put out some time back where we looked at all kinds of pediatric retinal imaging. Thank you so much for the opportunity.